So imagine you just walk into a clinic on your lunch break, right? You get this quick 15-minute procedure to cure your urinary leakage, and the doctor literally tells you that you can go right back to your desk.
Right, which sounds amazing.
It sounds like an absolute magic wand. But then, what if the instruction manual for that magic wand suddenly bans you from taking a hot bath or, drinking your morning coffee or even just lifting a heavy bag of groceries?
Yeah, that kind of shatters that illusion of the instantaneous zero consequence fix, I think. Because we always pitch these things as minimally invasive, which, I mean, they are.
Right, but
The tissue inside your body still has to do the very real physical work of healing.
exactly. So, welcome to this deep dive, everyone. Today, our mission is highly specific, but honestly, it's incredibly vital if you or maybe someone you know is navigating the pretty complex world of pelvic health.
It's a very confusing space for a lot of patients.
It really is. So we are dissecting a massive stack of medical guidelines, post-operative clinic instructions, and urological fact sheets. And we're trying to answer one very specific question, which is, what are the immediate recovery restrictions right after getting an outpatient urethral bulking injection for stress urinary incontinence?
And we have pulled from a remarkably wide spectrum of medical authorities here to get to the bottom of this for you.
Yeah, a lot of different sources today.
We really are looking everywhere. We have official guidelines from the British National Health Service, so the NHS, and then independent urology clinics like Keystone Urology.
Plus the huge ones, right? Like
Yeah.
Kaiser.
Exactly. Massive health systems like Kaiser Permanente, and even more specialized centers like Treatment GPS and the Women's Health Center of Southern Oregon. We basically want to give you a really comprehensive look at what the medical field is actually telling patients right now.
And for anyone listening who might not be intimately familiar with the terminology here, this procedure is heavily celebrated as a really rapid fix for stress urinary incontinence.
Which is that involuntary leakage.
Right, the leakage you might experience when you cough or laugh, sneeze, maybe do jumping jacks. And the doctor essentially just adds volume to the walls of the urethra so it can seal shut tightly under pressure.
That's the goal, yeah.
But as you are going to find out over the next few minutes, just because the surgeon doesn't use a scalpel, well, that doesn't mean you can just go run a marathon the next morning.
Definitely not.
You are going to learn exactly what you can, what you cannot, and what you absolutely must do in the hours and weeks following this procedure.
So to really understand these rules, I think we need to quickly set the scene of what actually happens in that clinic room first.
Okay, set the scene for us.
So you've just had the procedure. You've been in the chair for maybe 20 minutes total.
Super fast.
Very fast.
Yeah.
And the doctor used a tiny flexible camera called a cystoscope, and they administered, usually, 3 to 4 very small injections of bulking agent, and that goes directly into the inner wall of your urethra.
Okay, so what exactly is going into the tissue? Because the sources we looked at mention a product called Bulkamid, and it noted that it's 97.5% water and 2.5% polyacrylamide.
Yes, that's the most common one right now.
But how does a chemical name and basically mostly water actually bulk anything up? I mean, water is liquid.
Right. It seems counterintuitive, but what we call a hydrogel. So picture a microscopic three-dimensional sponge made of tightly cross-linked polymers.
Okay.
That's the 2.5% polyacrylamide. So the structure of that microscopic sponge, it traps and holds on to a massive amount of water molecules. And it does this so securely that the water functionally behaves as a soft, permanent gel.
Oh, wow. So it doesn't just absorb it and leak it out. It traps it.
Exactly. It creates these little, almost like plush cushions inside the tissue. And those cushions help the urethra seal shut properly when you experience a sudden spike in pressure.
Okay, so the injections are done. You have these new hydrogel cushions in place, and the doctor says everything went flawlessly. But your very first restriction actually hits you before you even make it to the parking lot, right?
Yes, immediately.
You are not allowed to go home until you successfully pass urine.
Yeah, the clinic staff will absolutely require you to void before they sign any discharge papers for you.
Why is that so strict?
Well, think about the physical mechanics of what just happened. They intentionally narrowed your urethral opening by adding volume to it.
Right, the cushions.
Exactly. But on top of that, your body is also going to naturally react to the needle punctures with an inflammatory response.
Like swelling up.
Yes, bringing blood and fluid to the area, which causes temporary swelling. So they have to ensure that the combination of the injected gel and your natural swelling hasn't completely swollen the passageway shut.
Ah, so it's basically a mandatory safety checkpoint.
It really is. They can't let you leave if you literally can't pee.
And depending on how that procedure was managed, there might be an immediate restriction on how you even get home. Like if you had any kind of general anesthesia or deep sedation, or even if they just prescribed you a narcotic painkiller, there is a strict universal restriction on driving for at least 24 hours.
You absolutely must have someone there to drive you home.
Yeah, which makes sense.
It is totally standard across the board for any procedure involving those medications simply due to, delayed reaction times and impaired judgment.
Sure. But once you actually get home and walk through your front door, the universal rule across all our sources for the rest of that first day is simple, just light activity only.
Yeah, the tissue needs a moment to accept this newly introduced gel.
But if I'm the patient and I'm sitting at home on day one, my hypervigilance is probably going to be through the roof. I mean, I just had this procedure to fix a huge disruption in my life.
Oh, absolutely. The anxiety is real.
Right. So if I start feeling a burning sensation or discomfort, my first instinct is going to be panic. Like I've already ruined the procedure or I violated a rule without knowing it. How do you know if what you're feeling is actually a red flag versus just normal healing?
That is such a common anxiety, and it's really crucial to separate normal physiological reactions from actual complications. So for the first 24 to 48 hours, it is completely normal to experience minor burning or a slight stinging sensation when you urinate.
Really? Just normal stinging?
Totally normal. You might also notice slight blood staining in your urine, kind of turning it a faint pink.
Okay.
You might even have a temporary increase in urinary urgency, where you suddenly feel like, oh, I have to go right this very second.
So none of that means the hydrogel is failing or falling out?
Not at all. That is simply the delicate mucosal lining of your urethra reacting to having a metal cystoscope and a series of needles pass through it. I mean, it's localized trauma.
That makes total sense. So how do they tell you to deal with it?
Well, to manage that discomfort, the guidelines explicitly state you are allowed to take mild over-the-counter painkillers. So things like paracetamol or ibuprofen.
Okay, easy enough.
And you can also place a warm, damp cloth over the external genital area. The gentle heat increases local blood flow and helps soothe that muscular discomfort.
Got it. Now let's shift our focus to the bathroom and your diet, because the advice we pulled from these clinical sheets gets incredibly specific and honestly a little bit contradictory at first glance.
It can definitely seem that way.
Right, because the guidelines strictly state you must avoid bladder irritants. This means no caffeine, no alcohol, and no spicy foods.
And we have to look at how those substances interact with the bladder and the urine. Caffeine and alcohol are diuretics, yes, but they also actively stimulate the detrusor muscle.
The detrusor muscle.
Yeah, that's the main muscle of the bladder wall. You really do not want a hyperactive, twitching bladder muscle when the sphincter right below it is actively trying to heal.
Oh, that sounds awful, actually. It's not great. Furthermore, those irritants change the chemical composition of your urine, basically making it more acidic.
And acid on a wound is bad.
Exactly. Acidic urine passing over fresh needle wounds will massively amplify that burning sensation we just talked about.
Okay, avoiding acid on a fresh wound is perfectly logical. But in the very next breath, these post-op instruction sheets instruct the patient to drink a massive, seemingly counterproductive amount of water.
Yes, a lot of water.
We are talking 2 to 3 liters a day, specifically to keep the urine a pale, clear yellow. And here's where I have to pause, because let's think about this. The patient literally just had a medical procedure because their bladder leaks under pressure.
Right.
And the immediate restriction is to avoid their morning coffee, sure, but absolutely flood their system with up to 3 liters of water. I mean, why on earth are we filling the tank we just patched? Isn't that asking for a leak and causing the patient way more anxiety? If you look at it purely from a volume perspective, yeah, it feels terrifying for the patient. But if you look at it from a healing perspective, it makes perfect physiological sense.
Okay, explain that.
Diluting the urine by drinking that massive volume of water does 3 vital things for your recovery. First, highly concentrated, dark urine is full of urea, uric acid, and salts. It's chemically abrasive.
Like we were saying with the coffee.
Exactly. Highly diluted watery urine just doesn't sting nearly as much when it passes over those fresh injection sites.
So you are basically just watering down the acid to protect the tissue.
Precisely. You want it as neutral as possible. Second, that high volume of fluid effectively acts as an internal mechanical wash.
A wash.
Yeah, it constantly flushes away any residual blood, cellular debris, or even microscopic bacteria from the procedure.
Oh, I see.
And third, because you are flushing the system so frequently, it drastically lowers your risk of a urinary tract infection. A UTI is a known risk anytime you introduce a foreign instrument into the sterile environment of the urethra.
Okay, using water as a soothing agent and basically an internal power washer definitely changes the perspective on having a full bladder.
It's functional hydration, yeah.
But speaking of the bathroom, there is another major restriction that patients have to follow. You are strictly banned from straining on the toilet.
Yes, the clinics are remarkably adamant about this. You must not rush, and you absolutely must not push, bear down, or strain to force the urine out.
That sounds hard to control if you're in a hurry.
You really have to fight that urge. You have to sit there, actively relax your pelvic floor muscles, and just let the bladder contract and empty naturally on its own time.
Why is that mechanical restriction so critical, though? Because I imagine if you sit down and you know you just drank 3 liters of water, but nothing happens immediately, the immediate human instinct is to push.
And fighting that instinct is paramount. Remember that localized swelling we discussed earlier?
The inflammatory response, right?
Right, because of that inflammatory response in the really tight space of the urethra, about 1 in 10 women experience temporary difficulty emptying their bladder.
Wow, 10%.
Yeah, the stream feels slow or hesitant or sometimes completely blocked. Now, if you strain and bear down, using your abdominal muscles to force it, you generate a massive wave of downward intra-abdominal pressure.
Which hits exactly where the doctor just injected the gel.
Exactly. You are forcing incredible pressure onto freshly injected, still settling material and inflamed tissue.
Yikes.
You can aggravate the swelling, making the blockage even worse, or potentially even disrupt the placement of the bulking agent before the body's had a chance to secure it.
Okay, so if you fall into that 10% of patients and you are sitting there perfectly relaxed, totally following the rules by not straining, but you truly cannot go, what is the protocol? What do you do?
If you truly cannot void, or if you begin to feel severe pain from an overly distended bladder, you must contact the clinic.
They don't just tell you to wait it out.
No, absolutely not. They will typically have you come back in and temporarily place a very small, thin catheter, usually just overnight.
Okay, just a temporary fix.
Right. This tube bypasses the swollen urethral tissue entirely, drains the bladder, and just gives your body 12 to 24 hours to calm down.
And then what?
By the following morning, the acute swelling has usually subsided. They pull the catheter out, and normal, unforced emptying returns. It's merely a temporary physical detour, not an indication that the procedure failed.
That's a relief. So we just talked about how straining on the toilet pushes a wave of downward pressure onto the pelvic floor. But that downward pressure doesn't just happen in the bathroom.
Definitely not.
Right. What happens when you pick up a heavy box of groceries or go for a run? That brings us to section 3 of our sources, which is physical activity. And if you are listening to this hoping for a unified medical consensus, prepare for a wild ride.
Oh, yes.
The sources we pulled are completely over the map when it comes to physical exertion, lifting, and exercising.
The variance in these clinical guidelines is truly something to behold. I mean, it serves as a fascinating case study in how different medical institutions interpret and manage postoperative risk.
Yeah, let's lay out the actual data from the sheets. So we have treatment GPS. Their recovery guide confidently claims you can resume all normal activities, including vigorous exercise, swimming, and even horseback riding after just 24 hours.
Which is wild.
Tomorrow. You can go ride a horse tomorrow. But then you look at Keystone Urology's guidelines, and they specifically say you need to avoid heavy lifting, which they define as anything over 10 pounds, and avoid strenuous activity for, quote, several days.
Which is already a significant departure from 24 hours.
And it keeps extending. The AWP Naples Clinic and Westville Urology, they both explicitly extend that lifting restriction to 1 full week. Then Premier Surgical chimes in and states you should avoid hard physical exercise for 2 to 3 weeks.
This keeps climbing.
And finally, Kaiser Permanente tops the charts. Their post-op instructions recommend avoiding heavy lifting and strenuous activities for 4 to 6 weeks.
6 weeks versus 1 day.
Right. So how do we reconcile this for the listener? How can one doctor say, go horseback riding tomorrow, and another reputable, massive hospital system says, do not lift a heavy grocery bag for an entire month?
It is an incredibly frustrating contradiction for a patient trying to do the right thing for their body. I totally agree. To understand why this massive discrepancy exists, we have to look at both the history of the procedure and the biological mechanics of healing.
Okay, walk us through it.
While the overarching technique of urethral bulking is basically the same, different clinics have historically used different agents. Things like bovine collagen or carbon beads, which behaved very differently in the body and degraded at different rates.
So they are basing rules on older materials.
Sometimes, yes.
Hmm.
Today, many use these modern polyacrylamide hydrogels, but beyond the material itself, clinics just have vastly different risk tolerances.
So Kaiser Permanente is basically just playing the ultimate long game of caution.
Yes, and their caution is rooted in the biology of encapsulation. I know you were talking earlier about a DIY analogy, sort of comparing the gel to a fresh seal of caulk around a bathtub, where you said you could literally squish the caulk out of the joint before it dries.
Right, like if you had turned the shower on too early, you ruin the fresh seal.
It's a good analogy, but let's adjust that visual because it's slightly misleading biologically. Hydrogels in the body do not dry. Remember, they are 97.5% water.
Oh, true. So they don't cure like caulk.
No, it's actually about cellular encapsulation. Think of it more like planting a new seed in loose, freshly overturned wet soil.
Okay, I'm picturing it.
If you stomp on the ground right away or run a lawnmower over it, the seed gets violently displaced. You have to get the surrounding soil, which in this case is your body's tissue and fibroblasts, time to pack in, generate collagen, and anchor that seed in place.
Oh, wow, that paints a completely different picture. The body has to actively build scaffolding around the gel.
Exactly. The gel doesn't do anything on its own. It just sits there until the body builds around it. When you engage in high-impact activities, like playing tennis, swinging a golf club, jogging, or heavy lifting, you drastically spike your intra-abdominal pressure.
And that pressure pushes down.
Every single time your foot hits the pavement on a run or you heave a heavy box off the floor, that pressure bears down violently on the pelvic floor and the urethra.
So the medical fear at Kaiser is what? The gel just squishes out.
Basically, the fear is that if you subject the urethra to massive pressure before your tissue has fully built that scaffolding around the injected gel, the bulking material could physically migrate. It could be squeezed out of its optimal position before the body locks it down.
Wow. So if a listener is sitting at home looking at their discharge sheet that says one thing and reading a forum that says another, and their body actually feels perfectly fine, how should they self-advocate? Like, how do they safely test the waters of physical activity in this massive gray area?
The consensus best practice when navigating conflicting medical sheets is to listen to your specific body, but err heavily on the side of protecting your investment.
Protect the investment. I like that.
Returning to a desk job, walking around the house, or taking a light stroll in 1 to 2 days is universally considered safe. It's actually encouraged for blood flow.
Right. Keep things moving.
But when it comes to heavily bracing your core, you really should give your pelvic floor at least a week or two to settle before putting it under heavy physical stress. Oh, yes. These are absolute staples in almost every post-operative gynecological or urological procedure. But the specific anatomical nuances for urethral bulking are fascinating.
Across every single source we reviewed, there is a strict nothing in the vagina rule. They are incredibly clear on this.
Very clear.
This means no tampons, absolutely no sexual intercourse, no sex toys, and for patients who manage pelvic organ prolapse, no insertion of incontinence pessaries. But just like physical activity, the timelines are wobbly here too.
Yeah, they vary wildly.
Some say 24 hours, some say 1 to 2 weeks. The Worcestershire NHS Trust in the UK goes as far as calling out a strict 30-day ban specifically on tampons.
30 days is a long time. The timeline variation again reflects conservative versus aggressive recovery protocols across different clinics. But the mechanical reason why the vagina is restricted when the procedure was technically in the urethra is due to anatomical adjacency.
Adjacency.
Right. The urethra sits directly next to and intimately shares a very thin anatomical border with the anterior wall of the vagina.
So they are effectively neighbors sharing a very, very thin apartment wall.
Exactly. Inserting a tampon or engaging in intercourse doesn't happen in a vacuum. It physically stretches the vaginal canal, which creates direct pressure and friction against that shared wall.
And that bumps the urethra.
Yes, which subsequently bumps and disrupts the healing urethra next door. Furthermore, inserting anything into the vaginal canal introduces outside bacteria into an environment that is currently highly vulnerable. I mean, it's trying to heal from multiple needle punctures right next door.
Which brings us perfectly to the bathing rules, because the risk of introducing bacteria is obviously central here too. The post-op sheets explicitly state you can take a shower immediately. Like you can go home, get in the shower, and wash off.
Yes, showering is fine.
But you are restricted from taking hot baths, swimming in a pool, or using a jacuzzi for anywhere from a few days to a full week. And if the goal is just keeping the area clean, why is a hot shower perfectly fine, but a hot bath is banned? I mean, they both involve hot water.
It is all about the mechanics of a deep soak versus a surface rinse.
Okay, what do you mean?
What is fascinating here is how the physical properties of the tissue and the bulking agent actually interact with heat and prolonged submersion.
Right.
When you take a shower, the hot water hits your skin, rinses the surface, and immediately runs down the drain, right?
Right.
It is a moving stream of clean water. But when you sit in a hot bath, you are deeply soaking the entire pelvic region in hot water for an extended period of time.
Ah. So the heat isn't the primary problem, it's the standing water and the deep tissue saturation.
That changes the way you view a bathtub entirely, doesn't it?
It really does.
That deep, penetrating heat from prolonged submersion drastically increases local blood flow and can actually soften the tissues. So you risk compromising the structural integrity of the area while it is trying to firm up and heal.
Oh, wow. I wouldn't have thought of that.
And secondly, just like the pelvic rest restrictions, soaking in a tub of standing water, even if you use expensive soaks or bubble baths, introduces a significantly higher risk of infection. You are immersing healing needle tracks in a stagnant pool of water that contains bacteria from your own skin.
Oh, that's a gross but effective visual.
Right. You really want to keep those fresh puncture sites clean, dry, and relatively cool.
It makes total sense when you map out the actual physiology of healing like that. So let's wrap this up and summarize the vital takeaways for you, the listener. If you are going in for a urethral bulking procedure, the immediate physical recovery is indeed rapid.
Very rapid compared to major surgery.
Right, you aren't dealing with massive abdominal incisions, and you aren't recovering from heavy general anesthesia for days. You can often be back to your desk job or your normal light daily routine the very next morning.
But that speed requires you to adhere strictly to the behavioral rules.
Yeah.
You have to stay incredibly hydrated to dilute your urine and mechanically flush the system.
Drink that water.
Yes, you must absolutely fight the instinct to strain or push on the toilet. And you need to embrace a careful temporary pause on heavy lifting, hot baths, and any vaginal insertion to ensure that hydrogel stays exactly where the doctor planted it while your body builds scaffolding.
It is basically a few weeks of strict discipline for a potential lifetime of relief. But as we close out today's deep dive, there is a lingering question here that isn't printed on any of these post-op instruction sheets from Kaiser or Keystone or the NHS.
No, it's not on any of them.
We've spent this entire time talking about the physical body, the swelling, the hydration, the lifting rules.
But this next part is perhaps the most profound and honestly often overlooked part of the entire recovery process. We know that physical restrictions only last a few days to a few weeks. But what is the psychological recovery time?
Right, because if you are a patient who has spent years, maybe decades, living with severe stress urinary incontinence, your brain has fundamentally rewired your behavior to protect you from embarrassment.
It becomes instinct.
Exactly. You have spent years unconsciously bracing your core every single time you feel a sneeze or a cough coming on. You tightly cross your legs before you laugh at a joke. You mentally map out the location of every single public restroom just to survive a standard, 30-minute trip to the grocery store.
It is a state of exhausting perpetual hypervigilance. And a 15-minute physical procedure, no matter how successful the hydrogel is, well, it doesn't instantly erase years of ingrained neurological conditioning.
No, it can't.
How long does it actually take the brain to unlearn that deep-seated fear? How many times do you have to sneeze unexpectedly without leaking a single drop before your brain finally stops bracing for impact?
That's the real question.
How long does it take a patient to truly, deeply trust their body's new seal?
That is the real recovery. The physical hydrogel might be securely encapsulated in a few weeks, but the trust in your own body, well, that might take a whole lot longer to rebuild. It is something really profound to think about for yourself or for the people in your life who might be quietly managing this exact journey. Thank you so much for joining us on this deep dive. Keep questioning the guidelines, keep learning how your body works, and keep diving deep.